us see what is the cause behind. So there is no doubt that it is a irritant contact dermatitis caused by accidental brushing of rogue beetles over the skin, resulting in release of its hemolymph, which is present in its coelom. It contains a potent vesicant alkaloid that is called beterin. That is the cause of this contact irritant dermatitis. So it is not that the beetle bites it or stings. It is due to the accidental brushing of it, it stays on the body. Accidentally, you try to brush it off, it gets crushed, or while movement of our body it gets crushed, then its body hemolymph is discharged, and that is the reason for this thing. And as these beetles, they move around night time or evening time, so the time taken by it to manifest is 12 to 14 hours. So the lesions are almost invariably seen during the morning time. People gets up from bed and observes this lesion. There is a pain, burning sensation. Here also the lesion is in the axilla. There is an extreme amount of pustule, and like inside the axilla it must be involved, and there is a huge amount of erythema, and casting has not set in. Both the area are involved, both sides of axilla are involved. But it is localized on the same area only. Mostly when the axilla is involved, face is involved, face is involved in a normal, healthy, immunopotent subject. At times there is a diffuse involvement. There is a lesion on the neck, the back is involved. There is a lesion on the leg, from the thigh to foot is involved. It may be due to recurrent contact on a short period of time, or there are people who have underlying atopy. They may not manifest as atopic dermatitis, but maybe they have a history of recurrent sneezing, recurrent coryza, they have underlying atopy, and they present in a more severe form because the trigger acts to bring out the atopy in them. And in immunocompromised state, as it is basically toxic immune-mediated reaction, in immunocompromised state, the presentation is more severe, or at times this get secondarily infected to lead into a more severe generalized lesion. Here is also another picture. Mostly pustules. Pustules are present with even to the distant area. This area also is involved. There is the site of lesion. There is crusting has formed in those areas. Oozing is there. In that area, pustules are there. But this involvement area is huge. In these areas, the papules are seen. These have not turned into vesicular pustule. Maybe with time, these will turn into vesicular pustule. In these areas also, the pustules are seen. Extreme areas, there are papules. Papules will gradually turn into vesicles. Some vesicles will be filled up with lymphocytes leading to pustules. So there is a huge amount of involvement outside the area of contact. So while treating them, these are basically very, mostly more than 90% cases, these are very benign variety presentation. Other than that, pain, stinging, burning, there is not much to worry about. But thing is that it looks so much like the herpes. People think that herpes has occurred, and usually they come for medical treatment, and people are very anxious in the presentation. And reassurance is very important to tell them that this is due to this thing, the insect contact with insect, and it is going to heal within 7-10 days. The people are mostly happy, but we give mild topical steroid so that the inflammation is less, the post-inflammatory hyperpigmentation after the healing is not so dark, and there is not much thick scar on it. Our intention is that thing. The pustules are mostly sterile pustules, unless it is secondarily infected. The mostly sterile pustules, so oral antibiotics are seldom required. But antihistamines we give because it is a mostly allergic reaction, If it is a diffuse involvement, extensive involvement, then oral steroid is required, because then like anaphylaxis-like reaction may occur. So then we give a short course of about 30 to 40 mg of prednisolone for 5 days we give. That causes less ill feeling. At times, the patients present with malaise, body ache, unwellness, that steroid, or at times NSAID only, that is sufficient. And they should be asked to use insect repellents during this period. They should be asked to use mosquito nets. And that awareness is very important. This is due to an insect, this is not herpes virus or Beetle Dermatitis. And from the doctor side, that if we know that this is the case, then and having a high quotient of that this thing may happen, then we can jolly well treat these cases. Suspicion should be there that this may be a case of Beetle Dermatitis. Then everything matches. We don't require to do histopathology, but like any vesicular irritant lesion, naturally we expect that there will be less cohesion between the epidermal cells, leading to spongiosis, and as it is an acute reaction, there will be neutrophilic spongiosis, and there will be reticular degeneration of the epidermis, and the accumulation will be supravasal in between the stratum spinosum and stratum basale. At times, few layers of stratum spinosum may be there. Then from the basal layer and few layers of stratum spinosum, and that will be making the floor of the gula, and the roof will be made by few layers of stratum spinosum, and over that stratum granulosum and the remaining. So it is all suprasal. In a severe reaction, even the dermoepidermal junction may be damaged, and naturally there will be loosening between the cells. So there will be vacuolar degeneration may be seen. There are acantholytic cells also scattered, and the epidermis, the dermis will show like any inflammatory perivascular infiltrate, mostly mononuclear infiltrate.